Hi, welcome to MBBS Online Lecture 2021. The topic for today's lecture is about the rheumatoid arthritis. In previous classes, we have discussed in brief that about the joint anatomy and typical synovial joint. In this lecture, we will be discussing some pathology related to joint, that is rheumatoid arthritis. Now, first of all, the objectives for today's lecture. First one is the introduction. We'll be discussing brief interview of the rheumatoid arthritis, anatomy of typical synovial joint. Because this disease is related to the synovial joint, so we'll be discussing briefly about the anatomy of typical synovial joint. The pathophysiology, how the disease is caused, risk factors, what are the causative agents for the rheumatoid arthritis, clinical features, diagnosis, how the disease is diagnosed, its management and treatment related to some drugs. Now the introduction. In previous pathological classes, we have discussed that ITIS means the inflammation, while the ARTH represents the joint. So arthritis is basically the inflammation in the joints, while the rheumatoid arthritis is basically the chronic systemic inflammatory. It's also inflammatory, but it has another factor that is different, that is not present in other type of arthritis. It is autoimmunity. This disease, rheumatoid arthritis, is autoimmune disorder in which the body produces antibodies against our self body tissues. So we'll be seeing the antigen antibody complex. As you can see in this diagram, there will be the antigen antibody complex related to the body's tissues. So let's get discuss about the synovial joint. A typical synovial joint has a joint cavity that is surrounded internally by the synovial membrane and externally by the synovial, or we can say the joint capsule, that is fibrous capsule. It has ligaments that provide structural integrity to the joint, articular cartilage that prevent the rubbing of the two bones, and there is a synovial membrane which contains synovial fluid. So the rheumatoid arthritis is basically related to the synovial membrane. Now the pathogenesis, how the disease is caused. Basically there are two factors that causes the disease. First one is the genetic, another one is the environmental. Genetic is basically the presence of HLA-DRB1 gene or HLA-DRB4 gene that is not written here. So presence of this gene in the individual is very susceptible to the disease. So genetic and environmental factor work together in causing the disease. In environmental, there is a mutation in the synovial membrane. Particularly, the amino acid arginine is replaced by the citrulline in a process called citrullination. So citrullination is basically the external factor that causes the citrullination. So the body recognizes citrulline as a foreign antigen. So T cells that are present in the synovial membrane or in the synovial cavity start recognizing citrulline as non-self antigen. This causes the release of cytokines from the T helper cell that causes activation of B cells. B cell differentiates into plasma cells that causes release of antibodies. The antibodies causes the complement activation. Complement activation is basically the indirect action of the antibody that causes the infiltration of immune cells, particularly B cells, T cells, mast cells. Now these mast cells and B cells, T cells cause the release of the cytokines and leukotrienes. So leukotriene these causes inflammation in the synovial membrane. So the synovial membrane become thick due to the inflammation that we call it pannus. Because the antibodies attach to the synovial membrane, therefore the synovial membrane thickens and we term it as pannus formation. Now the clinical features for the rheumatoid arthritis. First one is a joint pain and swelling. As you can see in the picture on the left, here is a joint pain with the swelling, and in the picture with the blue one, this is due to the this is due to the inflammation, the presence of fluids, exudate, filtration of exudate in the synovial membrane, weakness, malaise, and low-grade fever due to the prostaglandins and leukotrienes. Early morning stiffness, there is multiple small joints are affected symmetrically. It means that if the rheumatoid arthritis, if a person has a rheumatoid arthritis, his or her joints will be symmetrical affected, means left and right both will be affected, and it particularly includes the small joints that are metacarpophalangeal or interphalangeal joints. The swan neck and Botnier's deformity we can see in the X-ray and on the picture on the left, right. Sorry. So vasculitis with Raynaud syndrome is basically is another clinical feature of the rheumatoid arthritis, where we can see the cyanotic appearance of the skin with a less blood supply. In this picture, it is well described that the pen form, it is a normal joint while it is a rheumatoid joint with a RA. There is a joint swelling and penis formation. There is infiltration of macrophages, leukocytes, and erosion of the bone and destruction of the cartilage. Now the risk factors. First one we have discussed in the pathogenesis, that is the presence of HLA-DRB1. We termed it as genetic predisposition. Environmental factors and cigarette smoke. Cigarette smoke is basically related to environmental factors because cigarette smoke contains many irritant particles that may cause mutation in the synovial membrane and really causes certination. The obesity, hormonal infectious disease. Now the diagnosis, it is basically diagnosed based on the serology and imaging. Imaging includes the ultrasound and X-ray, while the serology includes the presence of a rheumatoid factor and anti-cyclic citrullinated peptide anti-CCP antibodies. These are the antibodies that are produced in response to the citrulination. So presence of these two factors and the X-ray imaging, we can confirm the diagnosis of rheumatoid arthritis. X-ray shows the erosion of the bone. Now, since we have diagnosed, now let's get to the treatment. Treatment and management include the prescription of the NSAIDs and non-steroidal anti-inflammatory drugs that inhibits inflammation. Since it's the inflammation, we use NSAIDs. Corticosteroids has a role in inhibiting inflammation. It inhibits phospholipase A2 that is released in response to cell injury that causes the conversion of phospholipids in the cell membrane to arachidonic acid and further into the cyclooxygenase and leucooxygenase pathways to prostaglandins and leukotrienes. Chloroquine is basically an anti-malarial drug that blocks mast cell degranulation. It stabilizes mast cell membrane, so further contributing to inhibiting inflammation. Methotrexate is anti-carcinemic drug that prevents immune cell mitosis. So mitosis of immune cells is restricted. Infliximab is basically the alpha TNF blocker that prevent release of alpha TNF, that is the factor that causes the activation of macrophages. Now the recent studies shows the immune therapy to be very efficient in rheumatoid arthritis. What is the immune therapy? Basically, it's a prescription of monoclonal antibodies that neutralizes the autoantibodies that are produced. The autoantibodies include the rheumatoid factor and anti-CCP antibodies. So no antibodies or autoantibodies will be produced in the body. That's all for this lecture. We'll see you in next video. Hope you like this video. If you like, share it with your friends and subscribe to the channel. Thank you.